my lecture will be on anatomy of the pelvis. I think we gynecologists, the problem is we always work within the pelvis. We're very good at working within the pelvis. When we go laterally, we're not very good. And that is the area where the gynaecologists work. So I think we need to learn the lateral part of the pelvis, not only the structures in the pelvis. So today I'll try and go through what a laparoscopist see during a laparoscopic surgery. There are a lot of structures in the pelvis, but we want to try and highlight what we can see and what we do in which kind of surgery. So what are the structures that we see in the pelvis? The first, we see bones and ligaments. Then we see organs. The organs are the uterus, tubes, ovaries, bladder, rectum, sigmoid, ureters. We see vessels, we see arteries, we see veins, and we also see nerves. Nerves can be sensory nerves, motor nerves, and autonomic nerves. So that's what I'm going to go through in this lecture. And also we have spaces, and the spaces are very important. They are midline spaces, space of Bretzius, vesicovaginal, rectovaginal, presacral spaces, and also the lateral spaces, which are the paravesical and pararectal. Pararectal are divided into Letsko, Okabayashi, and Yabuki spaces. So these are the areas that I'm going to cover. Now, when we look at the bones of the pelvis, there are basically three bones: the ilium, the ischium, and the pubis. And of course, there's a sacrum and coccyx. And when we look at the ligaments, then there are many ligaments in the pelvis. But the ligaments that we are most interested in is the anterior longitudinal ligament, which we look at when we do sacrocolpoplexy. All these ligaments are probably not something that we do during laparoscopic surgery. We may be able to look at sacrospinous ligament if you're doing vaginal surgery. From the laparoscopy, it may not be very clear. Sacrotuberous, no. Tendinous arch, yes. Cooper's ligament, yes. If you're going to do vertical suspensions. Now, these are the ligaments of the pelvis. This is the anterior longitudinal ligament, the ligament that is very useful to know when you're doing sacrocolpoplexy. The other ligaments are not that important in laparoscopic surgery. Now, these ligaments are important, the sacrotuberous and sacrospinous, because they divide the pelvis into the greater sciatic and the lesser sciatic foramen. We don't see these foramens, but we must know where they are when we are doing laparoscopic surgery. The important ligament is this ligament here, the lacunar ligament and the pectineal ligaments. These are ligaments. We don't do birch colposuspension very much nowadays, but these are ligaments that are important when you do colposuspensions. Now, this is the laparoscopic view of all the pelvic ligaments. When you go in, you open up this area, you'll be able to see the anterior longitudinal ligament. If you're going deep inside, especially in this area, you will be able to see the sacrospinous ligament. And this area is where the pectineal ligament is, where we will do when we do laparoscopic birch colposuspension. Now, when the muscles on the lateral pelvic walls can look very confusing when you're doing laparoscopically, you can see this ligament, which is the tendinous arch. There can be defect in this tendinous arch, which you can repair if you're doing defects in the lateral wall during laparoscopic surgery. And also, this will be the ligament where we will be stitching when we do a birch colposuspension. Next, we'll look at vasculatures. The vasculature that we commonly see are the aorta, the common iliac arteries, and the common iliac artery is divided into the external iliac, the internal iliac arteries. The internal iliac arteries got an anterior trunk and a posterior trunk. And the posterior trunk, which we rarely see, has got three branches, which is the ilioiliac, iliolumbar, lateral sacral, and superior gluteal arteries. These are arteries that we don't usually see, even when you are dissecting, but if you know them, it will be good. And the anterior trunk is probably the most important structures that we see during laparoscopic surgery. The obliterated umbilical artery is something that we always see, we always try to identify, because that will bring you to the superior vesicle and the uterine artery. So this is a very good anatomy to learn. Obturator artery is something that we see if you are going deep in the pelvis, you're going the lateral pelvic wall, you're doing pelvic lymphadenectomies, then you will see the obturator arteries and the nerves there. Sometimes you can see the middle rectal artery lying lateral to the lying slightly lateral to the uterosacral ligament. Let's look at them one by one. This is what you see in the anatomy book. It's always very confusing when you look at it in the anatomy book. common iliac artery dividing the external iliac artery. The important thing, note that the external iliac artery does not have any branches at all until it reaches this ligament. Inside here, we have an artery, but most of the time there's nothing there, branches at all. The internal iliac artery has got the posterior branch, and this is the 3 branches here, and we will not see this branch during laparoscopic surgery. An anterior branch is what we are interested in, and the anterior branch has got many branches, and the most important branch is the obliterated umbilical artery. You can see the umbilical artery that's coming up here, and then you will have all the branches. This obliterated umbilical artery. Then you have the superior vesicle and the uterine artery. And the other arteries are not usually very well seen. So this is how you look at it when you look laparoscopically. The branches that comes down, this is the external iliac artery, the internal iliac artery, and then you will have the obliterated umbilical artery. The obliterated umbilical artery will be going up with all the branches. I'll try and show them one by one. So this is the sacral promontory. When you're doing resection here, you can have the middle sacral artery here, and this is something that we like to point when we're doing operation here. So we usually open the peritoneum here, push these arteries, and then stitch the mesh here for this for sacral pulpopaxy. Now this is the arteries. This is the umbilical artery. So you can see it's the easiest artery to identify, and it's a good artery for beginners to identify. We usually pull this at the top part to show where it is. Then you can identify the uterine artery, which will be a branch here. And the first branch is always a superior vesical artery. And at the beginning, when I was starting to operate, I always tie up the superior vesical artery, not the uterine artery. The uterine artery will be just below it. It's a bigger artery. It's a very tortuous artery. And this is the artery that we're interested in. For beginners, this is the area that you want to learn, identify, and also tie up the uterine arteries when you're doing difficult surgery. So hold on to the uterine artery, hold on to the obliterated umbilical artery and pull. And the first thin artery will be the superior vesicle. The next one will be the uterine artery. So this is the triple division. You have the obliterated umbilical artery, the superior vesical artery, and the uterine artery. Okay, then again, you're looking at the middle rectal artery. It's not an artery that we usually see, but if you are dissecting on the uterosacral ligament, so lies slightly medial to it, go down. It sometimes it usually branches from the internal iliac artery. So sometimes it will come from this branch itself, and it is deep in the Okabayashi space, which I will tell you later. So the vaginal artery can come from this middle rectal artery. It can come from the uterine artery. So it is not something that is constant. So this is the laparoscopic view of the whole arterial branches. You have the aorta and then the external iliac artery, and then you have the internal branches of the arteries here. Okay, so when we look down, these are the branches that we're going to see. If in the surgery that I'm going to do later, if we have an opportunity, we will try and identify all these arteries when we do surgery. So next we come to nerves. When you look at nerves, there are different types of nerves. There's somatic nerves and visceral nerves. The somatic nerves are the iliohypogastric, ilioinguinal, lateral quadratus, the nerve of the thigh, genitofemoral, obturator, lumbosacral trunk. The visceral nerves are the superior hypogastric, the hypogastric, and the hypogastric. For us, the ones that we see often are the genitofemoral nerve, we do radical hysterectomy, and the obturator nerve. The rest of the nerves we don't see, but you're doing deep in the pelvis, then you can see the lumbos very far up, and I'll show you all. It is not something that we see, but you can damage it when you move the patient, when you position the patient. Superior hypogastric plexus is something very important. Hypogastric nerve and inferior hypogastric plexus, these are very important, especially when you're working in the Okabayashi space. So these are the nerves of the pelvis. This is what a textbook will show. You can see all the nerves up here. This is the subcostal, the iliohypogastric, the spinal nerves here. They are all very far away. The genitofemoral nerve is the one that runs here that we see very often when we are dissecting this area with big pelvic impediment. The obturator nerve is something that we see all the time. Right inside here. These are the nerves that the other nerves, femoral nerves, and the are not unless you're looking very deep in the pelvis. Generally speaking, we don't see these nerves. These are the of the cutaneous part of the nerves. This particular iliohypogastric and ilioinguinal nerve, if there's some problem with positioning of the patient, you can get injuries. And this affects the innervation of the groin, the inner thigh, and the labia major. So any kind of injury, usually positioning the patient, can cause the injury to this and can cause pain and paresthesia in this area, groin, inner thigh, and labia major. And this is the diagrammatic representation, the laparoscopic view of all the structures. You can see that this ilioinguinal, iliohypogastric nerves are very lateral. You will never see them. The genitofemoral nerve is what we see here all the time. And then you will always see the obturator nerve. These nerves, the sacral nerve roots, are something that now more and more people who are doing endometriosis surgery are getting into these spaces. I personally don't go into this area, but this is an area that is interesting to work with. And as far as the superior hypogastric plexus is on top of the sacral promontory, then it will give a branch that will go down, and that will be the hypogastric nerve, and then the other nerves will then join in with the inferior hypogastric plexus. And this is important, especially when you're working in the Okabayashi space, and if you're doing radical hysterectomy and also deep endometriosis. If you cut bilaterally, then you affect the innervation of the bladder. So this is how diagrammatically it looks. This is a workshop that I attended in Strasbourg, and this is a diagram from there. You have the superior hypogastric plexus, you have the inferior hypogastric plexus, and this is a right hypogastric nerve. These are the nerves that run in the Kobayashi space. And all these, all this S1, S2, S3, S4 will join the inferior hypogastric plexus, and then they will have a mixed, what they call a parasympathetic and sympathetic nerves that supplies the pelvis, the bladder, and the uterus. So this is how it is. So the area where you can damage is this area, the hypogastric nerve area. So this is again showing the somatic, the visceral plexus. This is the superior hypogastric plexus, and then the superior hypogastric plexus will then join, will have a nerve that's an inferior hypogastric nerve, which will join the inferior hypogastric plexus and then supply all the organs in the abdomen, in the pelvis. So next, let's look at the spaces. Now the spaces are very important because they provide a non-vascular area to the surgery. So knowing your spaces is very important, because if you open up the spaces, then we have more areas to work with. And the spaces can be divided into midline spaces, lateral spaces. The midline spaces are this space. What are these spaces? These spaces are actually peritoneal depressions formed by reflection of peritoneum between the organs and the pelvic wall. They are avascular spaces. They are filled with loose connective tissues and fats. So it's nice to work in these areas because you can push and then you can get a nice area, space there. And that is the place where all your structures will be, your vessels, your nerves. Now, these are virtual spaces but easily developable in order to separate the organs for landmark recognition. So here you can see the midline spaces. They are the space of Retzius, vesicovaginal space, the rectovaginal space, and then the lateral spaces. They are very huge spaces. They are paravesical spaces and the pararectal spaces. Now let's look at it one by one. Now the first is the, as I said, the midline spaces are placed in the middle of the sagittal pelvis. They're very useful. They are very useful planes and a lot of gynecological procedures for benign diseases. Now the first space is the vesicovaginal space. I think all of us know vesicovaginal space. We do this for cesarean section. We open this up and we do hysterectomies, open hysterectomies, and laparoscopic hysterectomies. It can get stuck when we do cesarean sections, and this can be stuck, because of endometriosis. So you must be able to get into space, and this is the important space for us to do hysterectomy. The next space is the recto-vaginal space. Again, this is a space that we actually rarely do. When we do normal hysterectomies, we just push the rectum away, and then we can do the hysterectomy. But when you have endometriosis, when you have recto-vaginal nodule, it's a very important space to learn to dissect. It's also a avascular space, not as easy as the vesico-vaginal space when it gets stuck. And this gives a lot of pressure when we're trying to separate the rectum away from the vagina in this area. So this is a very important space as well, recto-vaginal space. And most of the time when we dissect the space, when it's stuck, this will come from the lateral, medial, and then move the rectum downwards. Then we have the presacral space to try and separate the rectum from the space below it so that we can do bowel resection. So this is another space that is important, especially when you start doing bowel resection. Then comes the space of Brentzius. This is a space I rarely go into now. When I first started laparoscopic surgery, we used to do a lot of verge pulpal suspensions, and then we go into this space. It's another nice avascular space. You open up the space, push the bladder down, and you can be deep inside here. Here you can see the arcus tendinous, where the obturator nerve, obturator artery, the obturator muscle attached to the pelvic floor muscle, levator muscle. And this can be detached. You can stitch this, and you can do a verge pulpal suspension. You can take the paravaginal space and change the pectical line. So this is a space that is available to us, but now we rarely go to this space. Next, we come to the paravesical and pararectal fossas. Now, these are all connected. They're all connected spaces, but they are just, for terminology, we divide them into different spaces. The paravesical fossa, the pararectal fossa are separated by the uterine artery. The uterine artery actually separates the paravesical and the pararectal fossa. The paravesical fossa is separated into lateral and medial by the obliterated umbilical space. So they are all very, very nice spaces to go into when you are dealing with severe endometriosis. You want to go into these spaces. You want to open up the spaces, then you know where all the structures are. Now, the pararectal space has got a lot of terminology. Now, this is not an easy area to learn to dissect. Now, when you are medial to the ureter, that space between the ureter and the uterosacral ligament is called the Okabayashi space, and the Okabayashi space. So that is a space that is between the ureter and the uterosacral ligament. And that's an important space because all the hypogastric nerves runs in this space. So if you're going to do nerve sparing surgery, this is an important space to try and avoid cut this area. And the pararectal space is also divided, has got a lateral in the medial. The lateral space is called the Lascaux, space of Lascaux, and the medial one, as I told you, is the Okabayashi space. Then there is another space that is even more difficult to identify, which is medial to the ureter at the region of the cervix. It's beyond the uterine artery. So when you find the Okabayashi space, then you have a ureteric tunnel. The ureteric, when you open up the ureteric tunnel, that space between the ureter and the bladder is called the what you call as a fourth space, or the space of Yamuki. This is something that people, radical hysterectomy, will see all the time. Okay, so that's all for my lecture. It is very abstract when you show it on diagrams. If you go laparoscopically, you can actually identify. So try and see whether in the surgery afterwards we can show you all some of the spaces. Thank you.
Thank you, Dr. Selva. That was a very comprehensive presentation. I have a question, Dr. Selva. Can you explain the anatomical landmark and structure involved in the LUNA procedure? LUNA is the laparoscopic uterine ablation.
Ablation is something that we used to do a lot when I first started laparoscopy surgery, but we don't do that anymore. The whole concept is if your patient has got deep pelvic pain, if you cut the uterosacral ligament, you will have pain relief. Okay. Some people even go up and cut the hypogastric plexus to affect the pain. I think we don't do that procedure anymore. If you're going to do it, it's okay, fine. It's not very difficult to do. But you got to remember that the ureter runs very close to the uterosacrum. So it's good to dissect and push the ureter away before you cut the uterosacrum. Basically, what you're doing is you're burning and cutting the uterosacral ligament bilaterally to relieve it. So we don't do very much tonight.
Okay, with that, thank you, Dr. Selva.